topic, okay? Tumors. Not only is tumors at least 1/3 of all diseases, probably more than a third, but in terms of a pathologist's day, it's probably more than half of his day because, as you know, you might get the vision of a pathologist looking through a microscope all day to determine whether biopsies are malignant or not. And basically, that's what we specialize in our whole life, whether we admit it or not. No matter what you ask a pathologist what he does, no matter what he says, he basically spends most of his day, more than half of his day, probably looking at tissues to see if they're benign or malignant, or what the surgeons would call negative or positive. Okay, so neoplasia as our third big classification of diseases, after the degenerative diseases, after the inflammatory diseases, and now the huge topic, which is going to take 3 webinars. This is going to basically be our outline, and we'll probably be able to finish off at least the first 4, maybe 5 today. And then next Tuesday, 5 days from now, we'll finish off your big question, which is probably going to be exactly what causes cancer. But we're going to talk about that in 5 days. We're going to talk about all of the basics of cancer as seen from the eyes of somebody who has basically studied it most of my long life of 72 years. So we'll be talking about definitions of cancer, how their tumors are named, basically the patterns and biologic behavior of tumors, epidemiology, and then next week we'll probably go into what they call the molecular or genetic basis of cancer, and more into exactly what the biological or biochemical mechanisms are in carcinogenesis, both in starting it as well as progressing it. So this is not my words. I don't think I could define neoplasia as well as Willis can. And this definition has stood for many years, including now that we know infinitely more about genetics. And I'll read it to you because it's going to be the basis of what we talk about the entire next 3 webinars. It's an abnormal mass of tissue, abnormal cells, the growth of which exceeds and is uncoordinated with that of the normal or usual mechanisms for cell regulation, and that growth persists in the same excessive manner after the cessation of stimuli which evoked it. So in other words, let's say that we assume that something causes cancer, okay? Well, once it causes cancer, whatever those causes are might not even matter anymore. They still may be present after the tumor starts, ultimately from a single cell, but they basically, tumor basically grows once that malignant clone or that malignant, what we call transformation, has occurred. And as you could guess, like almost all the other diseases, the loss of cell or growth regulation is because of genetic changes or mutations in the mechanisms that regulate growth. And once that growth starts, it's autonomous. So normally, if growth is regulated by mechanisms, these tumor cells, whether they're malignant or benign, grow autonomously. And we use the word clonal as well, and that's derived from the fact that the original tumor theoretically starts from a single cell. So all of the cells that grow from that tumor, even though they may differentiate or metastasize or not metastasize or apoptose, basically has occurred from a single cell. That's what we call the clonal nature of neoplasms, of true neoplasms, benign and malignant. So how do you want to name tumors? Okay, there's a million of them, and basically pathologists have to know exactly the right terms and the right names. But I'm going to make it easy for you. I put down a little thing at the bottom, which I miraculously thought of yesterday. If a tumor has the name Oma in it, but is not preceded by Carson or Sark, that means it's probably benign. But there's a few exceptions to the rule. For example, a lymphoma is malignant. All lymphomas are malignant. Leukemias are malignant. All leukemias are not only malignant, but they are malignant cells circulating within the blood. Melanomas are all malignant. There is no such thing as a benign melanoma. Sometimes I'll use the term malignant melanoma just to reinforce the fact, or malignant lymphoma just to reinforce the fact. But if you only said lymphoma or melanoma, it would be malignant. And hepatoma. Hepatomas are all malignant also. So there's no such thing as a benign lymphoma, a benign melanoma, or a benign hepatoma. Now, if these tumors originate ultimately from generally connective tissue sources or connective tissue precursors. We call that a connective tissue or mesenchymal or perhaps even mesodermal origin, or we call these mesenchymal tumors. So if you remember from your histology, all of the things that were called connective tissue, like cartilage, like bone, like fibrous tissue, like blood vessels. If they are benign, they would be called as such. A benign tumor of cartilage is a chondroma. A benign tumor of fibrous tissue is called a fibroma. A benign tumor of bone is called an osteoma. Okay. Now, but remember, there's basically two types of general cells in the body. Not only are there connective tissue cells, but these are epithelial cells. And if you want to think of mesenchymal or connective tissue as ultimately having mesodermal origins, even though that's not entirely true, then the epithelial tumors have either ectodermal or entodermal origins. And that's not entirely true either. But when you think of the ectodermal structures like skin, or the entodermal structures like the epithelium of the lung or of the GI tract, these are the epithelial tumors, and they're generally called adenomas if they're benign, if they are from glands or from organs or tissues which are glandular, or papillomas. And a papilloma is basically any tumor that grows with a finger-like projections. We're going to see an example of that. And if, for example, a tumor is benign and it's cystic, but also grows in a papillary fashion, it might be called a papillary cystadenoma. Now remember, the word carcino or sarc is not in any of these names, is it? Another type of benign epithelial tumor, usually epithelial, is called a polyp. And most people would tell you polyps are not true neoplasms. They are not true tumors. Very often, they are just projections of normal, perhaps epithelial and connective tissue elements. But if you had a hard time understanding all this and you want to be correct, over 95% of the time, any tumor that ends in oma but is not preceded by carcino or sarc is benign, with the exception of lymphoma, leukemia, melanoma, or hepatoma. Okay, so here's the tumor. I don't know if you know that because it just looks like a bunch of fingers, but in this tumor, you can see that it is growing in finger-like projections. Okay, sometimes they might call this a villus pattern as well. Some people might call this a villus adenoma, but it is growing in a papillary fashion, so a papillary adenoma would also be a correct terminology as well. And every time when I'm in the lecture hall and I talk about a papillary tumor of anything, because I always wave my fingers in the air to show that they grow, whether they're benign or malignant, in a finger-like fashion. This is a benign tumor. Okay. Now, I know some of you are saying, well, could it maybe turn into cancer? And of course, the answer is yes. Benign tumors can turn into cancer under certain circumstances. Here is a colon. Maybe you recognize that. It's opened up. It's not like you normally see it. It's from a surgery. And you can see that there is something here that looks like a little ball or a little polyp projecting from the lumen. And you might call this a polyp. And if the polyp had glandular features, you might also call it some type of adenoma, okay? Maybe an adenomatous polyp or a villus adenoma or a tubular adenoma. But remember, every time I use the word adenoma, I did not have the word carcino in that. The malignant counterpart of a adenoma would be an adenocarcinoma. Here's a microscopic picture of that benign polypoid projecting tumor. You can see not only does it have glands, like the colon mucosa normally has glands, but it also is connected by polyp. So if you look at the edges of this polyp, you can see there is more like a normal colon mucosa. And then you can also see that the connective tissue in this polyp has blood vessels and fibroblasts and a regular connective tissue. So you would call that the stalk. Now, just to jump ahead 1,000 light years, what would happen if you were examining this polyp and you were trying to decide whether it was benign or malignant, but then you saw some glands within the connective tissue? Well, that would make your decision pretty damn easy, wouldn't it? Because then you would know it was malignant, okay? Because benign glands do not invade connective tissue. But we're going to get into that in many examples. Now, let's go into the nomenclature of malignant tumors. Most malignant tumors are either called carcinomas, if they're epithelial derived, or ecto or endo, or sarcomas, if they're derived from tissue or tissue cell precursors, which are connective tissue. So, for example, when we talked about the chondroma being a benign cartilaginous tumor, now we have a chondrosarcoma being a malignant cartilaginous tumor. We talked about a fibroma being a benign tumor. Now we have a fibrosarcoma being a malignant fibrous tumor. We talked about the osteoma being a benign bone tumor. Now we have a malignant counterpart called osteosarcoma. So it's almost always, with a couple of exceptions, every time you have the word sarco or sarc in a tumor name, it's probably going to be not only malignant, but malignantly derived from malignant precursors of connective tissue elements. And now we have the word carcino, or maybe we should call it a prefix carcino. Or in this case, it happens to be in the middle of the word, so you can't call it a prefix. Almost every tumor that has the word carcinoma in it, or even carcino, is probably malignant. So if it's an adenocarcinoma, it would be a malignant gland-forming tumor. If it was just called an adenoma, it would be a benign gland-derived or forming tumor. If we called it a squamous cell carcinoma, it would be derived from elements or precursors from the squamous cells, okay, no matter where squamous cells normally are. If a tumor looks like it is epithelial, perhaps a little bit like glandular cells or a little bit like squamous cells, but they don't really look like they are forming cells, glands or squamous areas very nicely, we might call that either a poorly differentiated carcinoma or an undifferentiated carcinoma. Well, some of you might be saying, well, how do you know it's a carcinoma at all? How do you know it's malignant at all? Could it be a sarcoma? Well, there are a variety of ways by staining these cells with markers, immunohistochemical markers, to determine whether they are carcinomas or not carcinomas, perhaps sarcomas. Now, we told you a little bit of a fib before, and it was today, and I said that a lot of people think of connective tissue tumors as being derived from mesoderm, and epithelial tumors, whether they're benign or malignant, as being derived from ectoderm or endoderm. But technically, remember, ectoderm, mesoderm, endoderm, these are big, big multipotential areas. So technically, carcinomas can arise from any of the three germ cell layers, okay? But when we talk about a sarcoma, it was probably a malignancy that derived from mesodermal or mesenchyme or connective tissue elements. We talk about a carcinoma, probably arose from elements from the ectoderm or endoderm that give rise to epithelial or glandular tissues. Well, here's another picture. This is a really good example. Some of you might recognize this as skin. And how do you know it's skin? Well, it's squamous, it's keratinized, and no, I don't think you can see any skin appendages. You know, almost all keratinized squamous epithelium is skin. I think the hard palate is keratinized, but this basically looks like skin. And you could see the the cells of the normal skin differentiate from the basal layer to the stratum corneum. They have various names, but there's also these little nests of cells underneath the skin, and they don't look like they are differentiating very well at all, but you can still recognize them as being very, very similar to the overlying normal epidermis of squamous cells. So this might be called a squamous cell carcinoma, okay? And why is it a carcinoma, or why is it even malignant? Well, the key word to differentiate any malignant process, or to define any malignant process, I think I should probably ask you this as a question rather than tell you. But if somebody asked you on the street or in a board exam, and believe me, this question has even appeared on the pathology board exams and the STEP exams, what is the one word that describes the character or behavior of malignancies? Does anybody want to take a stab at it? Aha, you got it. Thank you, Intishar. Invasion is the word. Or perhaps some people might call it infiltration as well. So this is a infiltrating squamous cell carcinoma. Here's more of it. Now, let's say that you realize this is a squamous cell carcinoma, and it looks a lot like the skin. And it even has these little whorled pools, which they call pearls, inside the tumor. And it looks a lot like skin. So this would be called well differentiated. Here is some more squamous cell carcinoma, and it doesn't have the little pearls, but it looks a lot like squamous cells. But one thing it does have, even though it doesn't have pearls, I put a couple of arrows here, which probably you can't see too well, so I'm going to blow it up for you, like zooming in on a microscope. And here are the tumor cells. And you could see between the tumor cells, you see these tiny little lines. They're called intercellular bridges. Histologically, they might be called desmosomes, or intercellular bridges, or tonofibrils. They generally all have the same name. So this is a malignancy, but because it has the tonofibrils, like you see in the prickle cell layer or the stratum spinosum of the skin, you could say it's still a squamous cell carcinoma, but it's not quite fully apparent or differentiated like the beautiful pearls that we see here. So you might call this moderately differentiated. Okay, and this is one reason why pathologists zoom in under high power whenever they see a squamous cell carcinoma. Maybe they want to see or document the fact that there's intercellular bridges, because no other types of tissue forms intercellular bridges except for squamous cell. Now, I hope that everybody here from histology or anywhere, or even logic, recognizes that these are epithelial clusters that are arranged like little tubes. These are glands, okay? This is what the glands of the colon might look like. These are glands of just about what anything might look like. And you might say, well, this tumor looks kind of glandular, but if you zoom in on it, the cells are somewhat darker than usual. They're not growing in a regular fashion. And the nuclei being at the base of the cell look like they come closer to the lumen. And maybe if you examine it even further, and we're not going to do this, so we're going to do it in the lab, you say maybe these little glandular, haphazardly growing glands might have a higher number of mitoses than you normally see for normal colon. These are all features of malignant glands. Another thing that you could say is perhaps some of these glands are not separated by connective tissue like they should be, like maybe you see here. These are 4 or 5 features that make glands malignant. But once again, this is what the pathologist uses in his brain. Now, let's say you're looking at a tumor like this, and you're looking at little clusters like this, and you're looking at it all day, okay? You're like in a trance, and you go, well, are these very, very poorly differentiated glands, or what they call abortive gland formation, or are these squamous cells? And you go, gee, they look sort of epithelial, and they're different from these lymphocytes or connective tissue cells that surround them. So is this a adenocarcinoma that's poorly differentiated? Is this a squamous cell carcinoma? And actually, if you took a vote with even some of the real pro-pathologists, they might be split in their decision. So you might call this a poorly differentiated carcinoma. And for example, if you knew that the primary was an adenocarcinoma, you might call it a poorly differentiated adenocarcinoma, and then you would start to see perhaps little tiny abortive glands. But let's just say this type of carcinoma, this type of malignant epithelial tumor, does not clearly form glands or look squamous or have intercellular bridges. Okay. Well, now that we have pretty much defined, benign tumors, malignant tumors, carcinomas, sarcomas, I have to add a few other things. Okay, there are a few exceptions to the rule, and think about it. Let's say that you were looking at a tumor that looked like it might be both carcinoma looking, which means epithelial cells, as well as sarcoma looking, which is malignant connective tissue cells. Then you might call that a carcinosarcoma. But let's say you're looking at a tumor had benign glandular components as well as benign connective tissue components. You might give that another name. For example, in the salivary gland, the most common type of benign tumor is called a pleomorphic adenoma. Some people call these also mixed tumors because they have both a epithelial or glandular as well as a benign connective tissue component. So tumors can have both epithelial as well as connective tissue differentiation, either benign, like you see here with the salivary mixed tumor, or malignant, like you might see a carcinosarcoma in various places. Now, if you remember, we generally talked about tumors so far as arising from either ectoderm, mesoderm, or entoderm. And you're probably thinking, well, could they arise from more than one of the 3 primary germ cell layers? Yes, and they can. If you have a tumor that arises from more than one germ cell layer, either 2 or 3, you would call that a teratoma. And because you're now talking about more than one epithelial layer, you're probably going to have both elements of glands or epithelial cells as well as connective tissue. And probably a really, really good idea or a good example might be the most common type of teratoma in the world is what they call a cystic teratoma. It's in the ovary. It's in women, obviously, often in younger women. It's probably the most common benign ovarian tumor of young women. And it has not only glandular or skin or sebaceous material, but also connective tissue like bone, like tooth. You know, there's even crazy things that are found in there, like muscle, like thyroid, like retina. So we're talking about really, really more than one type of cellular or tissue differentiation. And also, there are some omas which are not true tumors at all, or they're not true neoplasms at all. Okay, for example, a hamartoma is classically described as a disorganized mass of cells that are indigenous to the site of the lesion. And probably the best example of a hamartoma, even though there's a lot of them, is in the lung. If you remember, the lung not only has bronchi, but part of that bronchi is a cartilage protection layer. Okay, well, that cartilage can form sort of a benign tumor-like condition, and that would be called a hamartoma. It's not a true neoplasm. Now, another thing is called a choriostoma. Okay, now that looks like a big word, but choriostoma is better described and almost never use the word choriostoma. They usually use the word ectopic tissue. In other words, if endometrial glands normally are within the uterus, and all of a sudden you find them outside the uterus, like the ovary or the broad ligaments or the surface of the bowel, then you could call it a choriostoma, and it's not really a true neoplasm, it's just ectopic tissue. Probably the even more common situation would be for a surgeon to open up a belly, and he's looking at an abdomen, and he sees perhaps some tumor-like tissue on the surface of some of the abdominal organs, you know, like the liver or the stomach or the serosa of the bowel, and he finds little normal pancreas tissue. Well, that's called ectopic tissue or heterotopia. And of course, that is not a true neoplasm either. That's just normal tissue, like endometriosis, in a abnormal place. And these misnomers or exceptions to the rule we've already discussed. Hepatoma does not have the word carcino or sarc in it, but they are still all malignant. Melanoma does not have the word carcino or sarc in it, but they're all malignant. In fact, they're very malignant. Seminomas does not have the word malignant in it, but all seminomas of the testicle. You can even have a sort of like a seminoma of the ovary, but it's given another word, are all malignant. So there's no such thing as a benign hepatoma, a benign melanoma, a benign seminoma, a benign lymphoma, a benign leukemia, or a benign. They are all malignant, but sometimes they use the word malignant preceding it just to emphasize the fact that even though it doesn't have the word carcino or sarc in it, they're still malignant. Like, I think it's probably more likely for a person to say a malignant lymphoma rather than a lymphoma, or a malignant melanoma rather than just a melanoma. Okay, well, here's an example of what we talked about. This is a tumor of the ovary. You can see it's a tumor. Maybe you can dig out some hair and sebaceous material, but you could also see connective tissue elements like maybe bone, or who knows, maybe this was even a tooth. Okay, maybe microscopically you could see evidence for thyroid or other glands or bronchial epithelium or retina or glial cells. Okay, that just shows that a tumor that has all these different differentiated things probably arose from more than one germ cell layer. And whether these teratomas are benign or malignant depends on how well they differentiate. If they look like all primitive cells that do not differentiate into any recognizable tissue, that may very well be a malignant teratoma. And let me just make a little comment here. You know, when I learned pathology in medical school, and that was like way before you were born, that was like 60 years ago, maybe 50 years ago. The things I remember the most are what came out of my professor's mouth. They did not come from textbooks. They did not come from videos. They did not come from little books like, USMLE World or First Aid. What I remember the most and the deepest and the most permanent from pathology, and when I was a medical student like you, was the words that came out of my professor's mouth. And this was one of them. He said, a teratoma is malignant if the cells that comprise it do not look like they differentiate into anything. How do you like that? Perhaps those are almost his exact words. Here's another teratoma, and you know that this tumor has both bone and bone marrow, and fat, of course, which is part of the bone marrow. But look, it also has these glandular structures, and it has these little clusters of what may very well be sebaceous glands, and maybe you could find hair, or maybe you could find bronchial epithelium, but they are all well differentiated. They all look like what they're supposed to look like. So, assuming that this was the appearance of the entire teratoma, the teratoma was probably benign. Look at this. Here's a tumor. It looks like skin. It's keratinized squamous, but it also has hair follicles. It also has these sebaceous glands, which of course are at the base of the hair follicles. It looks like there's smooth muscle in here. And I'll tell you, if you have done a lot of surgery on ovarian tumors, or you're a pathologist, whenever you see a cystic teratoma, which this is because it has a cystic configuration, what do you think you might find inside of this type of cyst? Well, tons of sebaceous material and maybe a big wad of hair as well. The most common context of a benign cystic teratoma. In fact, it's so benign that a lot of people don't even use the word oma anymore. They'll use the word cyst. So these are also called dermoid cysts. So a benign cystic teratoma and a dermoid cyst are basically synonymous. Okay, let's get into the story a little bit deeper now. What are malignant tumors? Okay, well, in order to have a malignant tumor, you have to have a process, a very complicated process, which is called malignant transformation. And at the end of that transformation process, which we're going to go into in much more detail next webinar, you now have a growth of the transformed cells or cell. Okay? Now, if there was no invasion, it may very well be a benign tumor. But the one feature or the one word that makes any tumor malignant is the word invasion. And somebody already gave me, in fact, 3 people already gave me that. They knew about it. And sometimes the pathologist may use the word infiltration rather than invasion, but they basically mean the same thing. So here's the question. What's the difference between a benign and malignant tumor? The answer is one word: invasion. And of course, malignant tumors can and often do metastasize. Can a benign tumor metastasize? No. However, if you talk to a wise-ass pathologist, and I have talked to many wise-ass pathologists, they'll often say, well, there's a certain type of smooth muscle thing that can go inside of a vein, or what about endometriosis? It's a benign process, but it could metastasize. And remember, we said that's not really a tumor, that's just ectopic tissue. So let's make this simple. If a tumor invades, it's malignant. If a tumor metastasizes, it can't be benign. And we've also already mentioned the concept of differentiation without really defining it. So let's define it. Differentiation of cells or tumors is the degree to which they resemble the normal tissues from which they are ultimately derived. For example, a well-differentiated thyroid tumor might look like normal thyroid. A well-differentiated skin tumor might look like normal skin. Okay? So a well-differentiated tumor resembles the mature cells of the cells or tissue of origin of the tumor. A poorly differentiated tumor might not look very much at all like the tissues from which it was ultimately derived. So what does that mean? It means a poorly differentiated tumor might be very, very easy to diagnose as being malignant, but a well-differentiated malignancy might be very, very difficult to diagnose as malignant because it might look a lot like it's normal tissue. And sometimes the word undifferentiated is even worse than poorly differentiated. That means that the tumor cells may be so undifferentiated, they don't look like anything. You might not even know whether it's a carcinoma or sarcoma. And sometimes the word anaplastic is also used for a tumor that doesn't differentiate. But don't forget, the concept of anaplasia in general means malignant. So any tissue, any tumor that is anaplastic or is described as having anaplasia is malignant. Why? Because plasia means growth and an or a means none. In other words, there is no growth regulation. Now, as you might guess, or maybe thought about it already, tumors which are well differentiated and they look like the normal cells or tissues from which they were supposedly to be derived, they behave well. If they look well, they behave well. If a tumor does not look at all like the tissue from which it arose from, it's going to look poorly or it's going to behave poorly. Or sometimes they'll say a benign tumor looks good and a poorly differentiated tumor looks bad. And why they use the word bad? Because it is going to behave more aggressively. And when a pathologist grades a tumor, he's basically saying whether it's well, moderately, or poorly differentiated. Or he may give it numbers, or he may give it letters like ABC or 1, 2, 3. And this system has been around for a long, long time. Okay, now, in the next picture, I do not want anybody to accuse me of being a racist. But let's say you were in the neighborhood and you walked by these guys, you'd be afraid because they look bad, man. If you don't mind my expression, these guys look like bad motherfuckers. So you feel afraid because they don't look like they're nice and orderly. Okay, so if they look bad, they're probably going to beat your ass and behave bad. Okay. Now, here's a bunch of people that look orderly, they look good, they look holy. So when you walk by these people, you don't think they're going to mug you, okay? So what am I trying to say? And please, I'll have to think of a better picture than this for next year. Otherwise, I'm sure somebody's going to call me a racist. So what am I trying to say? If a tumor looks bad or poorly differentiated, it's going to behave bad biologically. It's going to have an aggressive biologic behavior. If they look good, they're going to behave themselves, and they're going to have a better prognosis. Now, that's the basis of grading. Okay, so and that's very important. And it's one of the few things a pathologist that can do that'll really give a patient hope, and a surgeon hope as well, and the family of the patient as well. However, It doesn't matter whether the tumor looks good or looks bad. If it's already metastasized to the lungs or the brain, even if it looks good, it has behaved bad. And you know what? That concept has been on almost every single step one exam I have ever seen, and also even on many pathology boards, believe it or not, even though it's so obvious. Now take a look at this. Take a look at this guy down here in the Southwest. I'm going to blow it up. If I told you this was histology 101, you would say, oh yeah, this is normal smooth muscle. You know, maybe it's the uterus, maybe it's a big blood vessel, maybe it's the muscular layer of a GI organ. Look, they have nice spindly cells. The fibers are cut longitudinally. There's no striations. And you could rattle on and on and on about how these are the most histologically normal smooth muscle as well. And take a look at this bigger thing now. If you looked at this, you might say, oh yeah, these are normal smooth muscle cells too. But guess what? These smooth muscle cells came from a tumor. So would you say that this tumor of smooth muscle is benign or malignant? You say it's benign because it looks exactly like it. So this is a normal smooth muscle, and this is a benign tumor of smooth muscle called a leiomyoma. Now take a look up here. Here's a picture of where most of them come from. This is a uterus, and it looks like there's about 10 or 15 of these little tumors in there. Yeah, they're benign because it looks exactly like normal smooth muscle. But do you think this woman, for example, might have some problems with maybe obstruction of surrounding organs? Or do you think perhaps this woman might not be able to have a baby because the endometrium is so disrupted? Yeah, but it's still technically benign. It's not going to invade, and it's not going to metastasize. Now let's talk about the cellular features of cancer cells. And this might be the domain of people who practice cytology, which look more at individual cancer cells rather than big sections of tumors. Probably the number one word to describe a cancer cell, which can also be called anaplasia, which means lack of growth regulation, is the word pleomorphism. Now, what does that mean? Well, it means, for example, if you're looking at these cells here, they all look like they resemble each other. They're about the same size, they're about the same shape, they're about the same color, but an anaplastic or malignant cells have a lot of variation in size and a lot of variation in shape. You may see big cells, giant cells, little cells, dark cells, light cells. So that's the concept of pleomorphism. And pleomorphism is itself is a feature of many malignant cells. What if you use the word hyperchromasia? Well, that means increased color, doesn't it? So if nuclei are much darker than they should be, maybe there's a problem with that nucleus in terms of its DNA and protein composition. So malignant cells are often described as being hyperchromatic as well. And if a nucleus is not only bigger than it should be compared to normal cells, but it therefore has a higher nuclear cytoplasmic ratio because the nucleus is bigger, and those are often the features of malignant or perhaps cells that are going to become malignant. Let's say that when you look at one of these cells here, and I'm going to go back to this again, when you look at these cells here at this big diagram of smooth muscle, the chromatin is distributed pretty uniformly. Okay, it's nice and smooth. But let's say that the chromatin is now clumped. That's another feature of a malignant cell. I mean, the malignant process is going on in the nucleus. Or let's say if a cell normally has one nice nucleolus, or perhaps very, very often no nucleolus that are easily seen, but now you have a large nucleolus, or multiple nucleoli or prominent nucleoli. Those are also features. Now, probably not a single thing that we talked about so far is indicative of cancer for sure. These are all little clues. What about mitosis? You know that cells have to divide, unless, of course, the cell is incapable of dividing, which some cells are. But if you looked at tissue, you should expect a normal mitotic rate. In other words, if you looked at a liver, if you looked at a kidney, if you looked at a spleen, you see occasionally there will be some cells which are normally dividing to replace the cells which have apoptosed. Okay, but let's say you find there should only be like one mitosis per 1 or 5 or 10 high power fields, and all of a sudden you're seeing 10 times as many mitoses. Well, that's a bad sign too. And of course, the location of mitosis or the type of mitosis. So let's say that a mitosis, if you remember, should basically should be bipolar. There should be a group of chromosomes going one way and another group of chromosomes going the other way, the opposite way, 180 degrees. But let's say all of a sudden you see the mitosis is going in 3 or 4 directions. Well, that, of course, is the single most strongest evidence that it's malignant. So whereas I told you that none of these features themselves are a characteristic of malignancy, they're just suspicious, they're not diagnostic. When you see a multipolar mitosis, more than just 2 directions, that's very, 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 very suspicious. Okay? And of course, another feature of a malignant cell is its loss of polarity. And what does that mean? Well, it means that if you look at cells, that the nucleus is often at the base of the cells, where the basement membrane is, and the other side of the cell, the apex of the cell, might be the side that perhaps faces into a lumen or something like that. But let's say the nucleus is not at the base of the cell. Let's say that in many cases it migrates up towards the apex. Well, that's often a malignant feature as well. So I hope that you understand from a cellular point of view that these are the features of malignant cells. Not a single one is absolutely diagnosis of a cancer cell, but a multipolar mitosis comes pretty damn close. Oh my God, take a look at this. Even if you've never seen a microscope before, even if you've never seen anything before, I bet you instantly, when you looked at this picture, before I said one single word, you probably go, this is malignant. Well, of course it's malignant. Look at how some of these nuclei are really big, and some are small, and some are really dark or hyperchromatic. And look at, none of these cells really resemble each other. That is pleomorphic. And look at, there's even looks like there's some chromosomes here that are strung out haphazardly. And I bet you could imagine something like this, perhaps being a mitotic figure, which you don't see, should see too many of. Here's a prominent nucleolus. So I got news for you. If I had like 500 pathologists, sleeping in a dormitory right now, and I instantly turned on the lights and put this picture in front of their eyeballs, within 1/2 a second, they would all say, malignant, simply because it has almost all of the characteristic features. And of course, would something like this be regarded as probably well differentiated, looking like whatever it should look like normally, or poorly differentiated? So not only is this malignant, this is highly malignant, or poorly differentiated, or more likely to have a bad prognosis or a bad biologic behavior. Okay, you know what? I threw a lot at you in the first hour, and we're at the end of the hour because all the sand is